Welcome to Nothing Without Us, stories and discussions about meaningful inclusion. We will talk about accessibility, true inclusion, and disability justice with stories, policy updates, discussions, and related commentary on the value of being accessible and inclusive. We believe life should be accessible for everyone, and everyone should be included in all aspects of life. I am your host, Annette Bourbonnier. I am a 70-ish-year-old woman with short gray hair and eyeglasses. I am sitting in a power wheelchair, and my service dog Kirby could show himself at some point during the podcast. This podcast is captioned. Please press the subscribe button at any time during the podcast if you have not already done so. It will not cost you anything, but it will help us make this podcast grow. You are also welcome to make comments in the chat and to give us feedback about what you do or do not like. We especially appreciate a thumbs up. Good afternoon. This is the first actual episode in our sub-series of Crip the Vote. And our guest today is Anita Jacobson, my very good friend, who is a clinical professor of pharmacy at the University of Rhode Island and is a candidate for the Rhode Island legislature in District 37 in South Kingstown. Welcome, Anita. How are you doing?
Great. Thank you for having me, Annette.
Hey. Well, it's really good to have you here. You're running for the legislature, and I really wish you a lot of luck in this.
Thank you.
And we're all about now talking about disability issues that most candidates don't talk about. So there are a couple of areas that I think that you're going to be ready to speak about. And one would be community pharmacy. It's really getting challenging to get the prescriptions that you want. You know, the formularies change all the time.
Yes.
And, so can you address that a little bit? And what can the state do to help with that?
Well, thank you. That's a great question, a great place to start. So I am certainly passionate about medication access and adherence. If people can't take their medications as prescribed, they're not going to achieve the health outcomes that they're hoping for. So making sure that the industry of basically pharmaceutical benefit managers, which are largely profiting off of the business of healthcare, and sadly it is a business the way that it's structured in our country. Maybe that could be a whole other topic of how we could restructure our healthcare system. But to address your specific question, absolutely, not only pharmacists but providers are spending so much of their time trying to ensure that their patients can get the medications that their provider, who has many, many years of training and expertise, has made a prescription for. And now we have all these prior authorizations or different tiers of copays that may make something inaccessible for someone. So there's other states that have passed good legislation. So we don't have to be the first. We can look to other states, and you would probably ideally cobble together legislation that took sort of the best of different states and how they have worked to start limiting these what we call PBMs, pharmacy benefit managers, to ensure that cost savings is going to the patient, to remove excessive hurdles. Of course, there will always be some tiers and some prior authorizations, and some of that is appropriate, but it just has ballooned. What used to be something we did once a month, twice a month, is now something that we're doing many, many times a day. Why is that? It's because more and more restrictions have been placed on medications compared to when I started out in pharmacy, over 25 years ago.
Right. Yeah, I personally encountered some of that myself in the area of insulin. Because they keep changing the formularies, and not all insulins are equal.
No.
And there are sometimes reasons other than the actual medication for sticking to a particular brand. For example, ease of delivery.
Mm-hmm.
Yeah, it is a big problem.
Well, and what you just said is so important, ease of delivery, right? So that's
Right.
part of adherence. Adherence includes how many times a day does the person have to use it, or times per week if it's something that's longer acting. How is it delivered to the person? If somebody has a mechanism of delivering it in like a pen, say an auto injector, maybe that's better for them, whereas for somebody else, they may have a strong preference for a vial and syringe, using your insulin example. So we have to trust our healthcare providers, who are the experts and have been educated in this, to make these decisions in collaboration with the patient. And that doesn't happen at the PBM level.
Right. And I think it also seemed to be making it challenging. Okay, I'm an economist, so when I talk about competition and ease of entry into a business, it's really challenging for small pharmacies to get into this.
So that is a really near and dear to my heart topic. Is I have only practiced in independent pharmacies. My whole career, 16 years in community pharmacy, was always at independent pharmacies. I started out at Earnshaw Drug in Wickford, if you remember them, years ago.
Yeah.
Wakefield Prescription Center, and then up at Central Drug in Central Falls for many years. So I've worked in a variety of different communities. And it is, as you said, really hard for independent pharmacies to compete, because in order to accept insurance, they have to accept the same deals that a large corporation would.
Right.
And so they don't have the volume, so they have to sign these contracts, or they can't be in the market.
Right.
But they can't be squeezed in the way that a huge corporation could be, and that they could cut some losses here and there. So we need to have equal opportunity for our small independent pharmacies, which are part of our community. People build relationships with their pharmacists.
Yes, definitely. And that's been hard to do over the past years,
Yeah.
unless you can find a small independent pharmacy.
Mm-hmm.
So, yeah, okay, that's a really good part. But something that kind of goes along, not affecting everybody, but has a big place in this state and in other states, is the other end, where people who have had substance issues and the risks involved in being an addict, and not being able to be safe, the risk of an accidental overdose and things like that. So I know that you were involved in helping set up the structure for harm reduction.
With naloxone, yes.
Right.
So harm reduction is sort of a big umbrella term,
Right.
and there are a lot of different aspects of that. So people who are using unregulated substances, who may not even be people who use opioids, right? So it could be somebody who uses a stimulant like cocaine or methamphetamine, or a person who buys on the street what they think is something like Xanax, or what they think is something like Percocet, but really it now all contains illicitly manufactured fentanyl. So part of harm reduction is to create a lot of different pathways for people who are still using unregulated substances to stay safe, and hopefully eventually be connected to treatment and recovery. So the harm reduction centers that you mentioned, those are really being led by an amazing organization in Rhode Island, Project Weber Renew. But there are also many other harm reduction organizations, the Parent Support Network, AIDS Care Ocean State. I'm at the University of Rhode Island in the Community First Responder Program. So our piece is really more related to naloxone distribution. So we have a service where anyone in Rhode Island can go online, take a short training to learn how to give naloxone to a person who's having an overdose, and we will mail it for free to their home. So that's our contribution to the larger zeitgeist of harm reduction services in Rhode Island.
Well, that must bring some comfort to parents who don't have any idea anymore how to handle things, and at least they know they've got one tool
One tool,
that can, save a child's life.
Yeah, we actually tell people to think of it like a fire extinguisher.
Right.
It's something that you have. We all have them in our home. We all kind of hope we never have a fire that we need to address, but you wouldn't feel safe not having a fire extinguisher. Right. So like that naloxone, we want all community members to feel empowered to have it, and they could save someone else's life, someone they love, as you mentioned,
Yes, right. And that's what I think of is, I've raised a teenager. I know the risks involved in raising teenagers. I work at the university and I see, what students go through, and I, think that would be a really good thing to have. And bring a lot of comfort to someone to know that I have one thing I can do to help.
Yes,
right.
Yes. Another, aspect of harm reduction that we do is distribute other supplies. So fentanyl test strips, so that somebody could, if they buy something and they're worried that it could have fentanyl in it, they could test it to see if fentanyl is present. We also have some sort of safer kits. They don't reduce the risk of overdose, but they help to reduce infection spread among people. So safer sniffing kits, safer smoking kits to help reduce burns and cuts and the spread of infections.
Right, yeah. Have you seen much use in Rhode Island of Tranq?
Right, so that is, for people who aren't familiar with it, xylazine.
Right.
So that is being introduced into the unregulated drug supply, and yes, it is here in Rhode Island. It can lead to severe infections and skin wounds that people may have, but it also, coupled with fentanyl, can worsen the risk of an overdose because it's a sedative. Yeah. So it makes you sleepy, and then plus fentanyl, that's a bad combination. So yes, it is worsening the already ongoing crisis that we've had, for more than a decade now.
Is there a way yet for that to be tested?
Right. So certainly there are drug checking services in some states where they use a mass spectrometer and they can actually assay, like if people, so Massachusetts as an example does that. In Rhode Island, we have the fentanyl test strips for distribution. Xylazine test strips are still being sort of looked at critically for their accuracy. So when those are approved for us to distribute from the Department of Health, we will be distributing them. We don't currently distribute them in Rhode Island.
Right. It'd be great if they had them at least in the harm reduction centers.
Yes, absolutely.
So that,
I agree. Or better yet, the actual machines would be ideal. So the testing strips, it's kind of the same thing as like a home test versus a lab test.
Right, yeah.
I would love the harm reduction centers to have the lab test so that they have the gold standard. We should invest in that. They should have something that could tell you, here's every substance, because there are other toxins beyond just fentanyl. There are all sorts of contaminants that can be in the drug supply that could cause kidney damage, that can cause things like suppressing the immune system. So it's there's
Scary
a lot.
World out there.
Yes.
Right. You said something though just now that is touching something that's very near and dear to me, and you talked about investing. And I think that this is something that we're always short-sighted on in looking at things as a cost instead of as an investment in our future, in the people of the state. And it's something I hear all the time as a person with a disability, but that's a really important way of putting it, that it's an investment that we need to make. So that is really good. Now, one more thing, let's try to talk, and I know you're not going to be able to solve this single-handedly, but I do hope that you get to address it. When it comes to disability, we have what I call PEPs, the poverty enforcing policies. So people who want to work, we have finally released some of the restrictions, but there's still very many restrictions on how much you're able to earn, and if you earn over that fictional limit, you lose critical benefits that make it impossible for you to live and survive. Do you think that we have any hope of really, you know, are we going to piecemeal it all, or can we find some kind of way of changing a system to look at this and say, well, you know, that's not realistic, that's not reasonable, why aren't we supporting rather than preventing people from living lives?
Oh my gosh, I hope so. I mean, that has been an experience, a learning experience for me. So as you know, I have an adult child who has a disability, so is on state Medicaid for since, you know, very young age. It was Katie Beckett, and is now transitioning into adult services. And it's been shocking for me in filling out the forms every year how low these thresholds are for what, now he's been a child, so it's been a different situation, but those cutoffs aren't any different for someone who, you know, he has a severe and profound disability, but there's, I mean, you say disability, that's a huge spectrum.
It is.
And so to force people to live in poverty in order to receive the benefits that they need for healthcare and to live safe and happy and productive life. I mean, to me, I think it's, I hope, just a lack of awareness about how bad it is, and that shining a very big spotlight on that is what we need. Because the more people I talk to about it, they're like, I had no idea. I hear that frequently. We need everyone to know about this issue, to know that we are forcing people with disabilities to live in, my opinion, a level that just is completely unsustainable and is inhumane to prevent people from being able to maximize their earning potential the way that anyone is. You know, that's an equity issue. It's a human rights issue.
Yeah, I agree. The policies are not set up that way.
Yeah.
And poverty levels, they're all measured against this fictional poverty level, which has no real meaning.
And is so low to live in this state that it's laughable, the level that it is.
Right. I mean, it was the actual poverty levels were actually originally designed to study what level people were living at, and having research on, you know, oh, this area has, you know, extreme poverty, and this area doesn't, you know, that kind of thing. But then it's used now as a target. For what people's incomes, if you go over that income, you're not considered poor enough to have Medicaid. So for a $500 extra earnings, you might lose $100,000 worth of disability-related benefits, and it's scary.
It's really bananas, actually.
Yeah, right. Well, I'm hoping when you're in the legislature, we will talk about this more and maybe do something to you know, really inform people, inform the public, and inform legislators and policymakers that, you know, the 1950s are done, and we need to kind of move into the 21st century and look at investing in people with disabilities and supporting their efforts rather than preventing them from being able to survive.
I can't agree more.
And I think economically it's a good thing for the state if you do that, because let's face it, if you're earning money, you pay taxes.
And you buy things.
Buy goods and services, which employ more people, who then pay taxes and buy goods and services. It's a basic economic driver.
Well, and as the economist, you know.
Yeah, I do. And I kind of know both sides of this issue too. So, you know, Anita, I really, really appreciate you coming. This has been very helpful. I wish you good luck in your race.
Thank you.
You know, and for my audience, thank you very much for listening. I'm Annette Bourbonnier from Nothing Without Us, Stories and Discussions of Meaningful Inclusion. Please follow me at patreon.com, Nothing Without Us, and also on YouTube, and you can also find me on LinkedIn, Threads, X. I'm sorry,
all the things.
I haven't been able to get off that yet. You know, and Please tell people about this podcast. The more people that know about it and become supporters, the more easily it will be to get other speakers to come on, like Anita, and if they want an audience. So support us, become a member. It doesn't cost anything, by the way. Give us a thumbs up on our rating, and if you have comments, especially if you want comments about future presentations, please note them in there. I will be checking all comments. Again, till our next Nothing Without Us, this is Annette Bourbonniere.